Hi, this is Dr. Centeno, and this is the talk I recently gave at the Med Rebels conference in Austin, Texas. So, we're going to talk today about why interventional orthopedics will be the next interventional cardiology. These are my disclosures. My background. I began using stem cells to treat orthopedic conditions in 2005, published 21 peer-reviewed publications in this area. We have a university-style stem cell research lab as part of our Colorado practice, which is pretty unique. And those are some of the toys we have that you see off to the right there. And we're tracking about 11,000 stem cell-treated patients in a nonprofit registry. So interventional cardiology really changed the landscape of cardiac care. In the early 90s, bypass surgery ruled the day. Cardiac bypass surgery with the big sternotomy scar was what everyone got who was in their 50s who had some angina. And if we look at the cabbage rate, which is the name of that surgery, it was 141 per 100,000. Then from 2001 to 2008, there was a 14% decrease in that surgery. And then by 2015, there was greater than a 60% drop in that surgery. And all of that happened because interventional cardiology came and replaced invasive cardiothoracic surgery. In fact, today it continues to replace invasive cardiovascular surgery. So what is interventional orthopedics? It's the injection of orthobiologics to facilitate healing of bone, tendon, ligament, muscle, or cartilage. And it's the precise placement of those injectates into damaged structures using imaging guidance. So what is interventional orthopedics? Well, right now, we have simple injections on the one hand and massively invasive surgery on the other hand. But interventional orthopedics is precisely getting into specific structures to replace the need for more invasive surgery. So if you look there, you can see all of the different structures in those three joints that we can access with interventional orthopedics. And that's not something generally your surgeon can do, certainly not with a needle, and that's not something the average physician can do. This is a skill that needs to be learned. So these are some examples. This is actually a case I had this week of a patient who has what's called a bone marrow lesion. And this is the bone marrow lesion, this light area, otherwise dark bone. And one way to treat this would be injecting just into the joint, which I'm doing here with this needle. But at the same time, in our experience, and based on some recent research we've done, injecting into that bone lesion will also improve outcomes. So you can see here another needle coming in and actually going into the bone itself. And this is X-ray guidance to make sure that I'm getting to the right place. So that's interventional orthopedics at its best. Or a patient who needs to have their ACL injected. And this is injecting both bands of the ACL. Now, this is a very complex procedure, and we invented this procedure. As far as we know, no one else was injecting both bands of the ACL and documenting it under fluoroscopy prior to us performing this procedure. And initially, a lot of people tried ultrasound, but you can only get down here on the bottom. You can only see the bottom part of the ACL with ultrasound. So we needed fluoroscopy to be able to inject both bands of the ACL to cause ACL repair. Or in this case, this is a shoulder labral injection, superior labral injection. You can see the needle coming off from the left, from the right there, and you can see the contrast accumulating right there, which is where the superior labrum is. So this is injecting stem cells into the superior labrum. Again, this is not a procedure that your orthopedic surgeon is going to know how to do. This is not a procedure that the average family medicine sports doctor is going to know how to do. These are procedures that you need to be trained in very specially. Or in this case, this is also interventional orthopedics. This is using ultrasound to inject growth factors around the median nerve. Now, that's a 30 gauge needle, and that's the size of a pea for scale there. To give you some idea of what fine microsurgical type work this is, and the dark stuff is going around the median nerve there. Or injecting the thumb capsular ligaments, again with a 30 gauge needle, in this case with platelet-rich plasma, and injecting those capsular ligaments and intra-articular. So you can see there, again, a 30 gauge needle about as thick as a toothbrush bristle being used to inject these very fine structures around the thumb for thumb arthritis. So what can we inject right now in interventional orthopedics? In the United States, we can use bone marrow concentrate, platelet-rich plasma, fat grafts, and cytokine-rich serums. In the future and outside of the U.S., we can use culture-expanded allogeneic and autologous mesenchymal stem cells, stromal vascular fraction, other stem progenitor cells, and in the future, likely recombinant growth factors that'll be made specially to facilitate healing. And exosomes are also coming on the radar. And what tools are available in 2017? Well, we actually have a good number. We have advanced imaging with regard to fluoroscopy and ultrasound. We have microtrocars, steerable needles, ultrasound-assisted percutaneous tenotomy, percutaneous discectomy, percutaneous carpal tunnel release, percutaneous arthroscopy. So already there are tools that we can use, but many more tools will come down the pike in the future. So a complete interventional orthopedic practice can replace the need for about 70% of all elective orthopedic surgery on peripheral joints, spine, and in some bone cases, in particular AVN and non-union cases. And obviously the advantages include that this is less invasive, you've got quicker recovery times, and preservation of the biomechanics. Let's focus on 3 areas today, just as an example. We'll focus on knee arthritis patients that require a knee replacement, shoulder rotator cuff tears, and we'll talk a little bit about knee ACL tears as well. So total knee arthroplasty, aka knee replacement. Now, what's really fascinating is this is a massively invasive procedure. I mean, it's an amputation of the joint and insertion of prosthesis. And despite that, we only have one randomized controlled trial to date that's been performed, and the results weren't great. The number to treat, which is the number of patients you needed to treat to get a 15% functional improvement or more, was 5 to 6. That meant that you had to amputate the knees of 5 or 6 patients before you got one person who said that they were 15% or more better. Now that's pretty disturbing. That's not a good result. And 3 and 4 patients by 1 year felt good enough with just physical therapy that they canceled their surgery. And if we look at the analysis of 2 large government data sets, most in OAI, where they looked at and tracked these patients, what they decided wasn't really all that great for knee replacement. They decided that this was not cost effective for most patients, meaning that they didn't see enough functional improvement in most people for them to state that these procedures were a good idea. Now, we all know someone who's had a knee replacement and thinks it worked well. So how does this fit? I think it fits because we've been pushing knee replacements on younger and younger and younger patients. And I think those patients are much more likely to be dissatisfied versus the average 60 or 70-year-old who can't walk the mall and who just wants to be able to walk the mall. So can we replace the need for a knee replacement? So these reported outcomes use what we call high-dose bone marrow concentrate. This is a same-day stem cell procedure, and where we make sure that we have very high concentrations of stem cells within the mix. So let's look at the information that's in our registry next. So this is an analysis of all the information that we had on patients who had knee arthritis. So we had around 6,000 knee procedures as of March. We had about 3,500 of those that had knee arthritis as their primary diagnosis, and about 2/3 of those patients were knee replacement candidates. And when we looked at the knee replacement rate despite treatment, it was about 12.7%. So pretty good. We prevented a lot of patients from getting knee replacement. And if we look at our published and ongoing knee arthritis research, we had pretty positive outcomes in a large case series of 840 patients. We've also looked at a registry-based dosing study that established a minimum dose per knee of 400 million total nucleated cells. And we have a knee osteoarthritis randomized controlled trial. Now, these are the trial results, and these will be published soon. We're just completing writing this up. So this study is done now out to 2 years. And what's interesting, as you can see here, for the function scores, the pain scores, and the KSS scores, very nice results versus physical therapy. This was a crossover design with physical therapy. But we've been doing this a long time. And, you know, there are kind of 3 phases of procedural adoption. Right now, in the last 24 months, we have a lot of people that just started doing stem cell treatment for knees, and they're in the first phase. This is magic, and it helps everybody. And then you get to the second phase, which is, this is great, it helps almost everybody, but you start to see some failures. And then after you've been doing it a very long time, you get to the third phase, and that is, let's figure out who's a good candidate for this. And that's the phase we've been in for quite some time now, which is, this is a great, helpful procedure, but we have to better dial in who the people are it's appropriate for and who it's not appropriate for. So who's a good candidate for knee OA stem cell treatments based on registry data? Well, we looked at KL grade, or the osteoarthritis severity, and it wasn't a good predictor, which we were very surprised about. We've looked at age, sex, and BMI, and they weren't all that predictive. And those are the usual suspects for orthopedic procedures. And then we did see that multiple prior surgeries and multiple joints were negative predictors, but that really doesn't allow us to hone in on a good prediction tool. So is there a better way to predict outcome for this procedure? Well, if you look at how a farmer would do it, he would measure what's in the soil and fertilize and then plant the seeds. So that's really been our goal. Is it all about what's in the soil, or what we would call the knee microenvironment? So we've been performing a multi-year study now about at N equals 250, meaning 250 patients. And we draw a 1/4 cc of synovial fluid from the knee. We use microarray multiplex ELISA to measure 25 growth factors and cytokines. We run that through a neural network tied to registry outcome, and we can predict, or we're trying to predict, good or poor candidates. And again, we're analyzing 25 growth factors and cytokines, and the model is at about 91% accuracy in picking good responders to the procedure. And this is the output of that model with regards to growth factors and cytokines. in order of significance towards outcome. The ones that have the bigger bars are predictors of outcome. The ones that have the smaller bars are not predictors of outcome. And we're going to begin a multi-site study in the first quarter of 2018 using this tool at many, many different places around the country in order to really test this out in the field to make sure it still works when we go beyond just our clinic in Colorado. So now let's switch gears to rotator cuff repair. And what we're talking about here is percutaneous implantation of HD-BMC, the high-dose bone marrow concentrator, a same-day stem cell procedure with ultrasound into weak or torn areas of the tendon with fenestration. And fenestration, for those of you who don't know, is poking lots of small holes in the tendon, similar to aerating your grass in the spring. So we published a large case series, about 200 patients showing positive outcomes, and we actually have an RCT underway here. And these are the RCT results. This is about halfway recruited. This is an N equals 50 study. This is 28 patients. We have a crossover at 6 months with physical therapy and a 1-to-1 allocation. You can see here from the functional scores a stark difference in just physical therapy. We also have 3D ultrasound data sets on all patients, and we're in the middle right now of a blinded reader study on the before and after images. And if you've not seen 3D ultrasound, it's kind of neat. It's a little bit like an MRI. You can fly through it. And so it's not really dependent on how you hold the probe as far as what you can see. So it really allows a blinded reader to go back in and see if the tear has gotten any better physically as well. So let's switch gears once again to knee ACL tears. So if we look at ACL tear types based on MRI, I would say that we need to almost reclassify how we look at these from a regen med standpoint. And that is looking at partial tears, full thickness, non-retracted tears, and what I would call full thickness or no tissue retracted tears. And we can treat about 70% of all the tears that currently get surgery, but it's right now confined to these two categories. So let's look at our ACL injection experience to try to heal ACL tears as of early 2016. So we had at that point about 7,800 total knee patients in the registry. Approximately 4,800 of those were knee cases. And if we looked at any patient who had had bone marrow concentrate injected into their ACL for any reason, and that included a lot of patients where we were treating secondary laxity, it was 758. If we then narrow that down to either an ACL for a known tear with or without another structure, that was 157, and we had 37 pure ACL tears, nothing else going on, which are the ones that we decided to really focus on. So what we're talking about here is a precise fluoro-guided ACL injection into the origin and insertion of both bundles with high-dose bone marrow concentrate or a same-day stem cell procedure. So this is the kind of thing that you can see, which is fairly remarkable. If you choose the right patients, you can get this type of ACL, which is read out by the reading radiologist as a complete ACL tear. And 3 months later, in a relatively young patient in her early 30s, you can see the ACL return to normal signal. And I can tell you, it's got normal biomechanical properties on exam, and it's robust, meaning that these people go back to full activities without surgery. This is just a precise injection of stem cells into their ACL. So how long does it take for these changes to happen? So if we look at this progression here without surgery, you can see from the far left, we have a completely blown out ACL between the dashed yellow lines. And then we can see over time here at around 11 months, and this is an older patient, we're getting to a more normal ACL signal. Now, in some patients, this can happen in as quickly as 3 or 4 months, and in some patients, it takes longer. So in this case, in the white dashed circle there with the red arrow pointing to it, you can see more of a blunt edge tear, a non-retracted tear in the ACL. And we can see here at 5 months and then at 9 months, and we get to complete healing at 9 months. So it really depends on the type of tear we're dealing with, the age of the patient, and probably on the technique. We've gotten better and better at placing cells in the ACL as time has gone on. So how do you look at outcome here? Who's a good candidate? Who's a bad candidate? We focused initially on offset and then more recently on morphology. So the offset is the degree of posterior translation of the femur versus the tibia, and it can be measured very easily on MRI. Now, initially, we really believed that the offset was key to predicting failures, and just reviewed about 50 before and after MRIs with some treatment failures and re-tears in there. Morphology of the tear is likely as important as the offset, is what we determined. And we've created a candidacy tool that's used now by our network providers to look at offset morphology to try to pick who's the best candidate for this procedure. One pointer from our candidacy data is that if no tissue connects from the origin to insertion, that equals 100% chance of eventual failure, even if you detect some proto-tissue on post-injection MRIs. And we actually have an RCT ongoing right now. We've so far published 2 MRI case series showing good evidence of repair on MRI. The second one talks about re-tear rates, which are lower than surgery. And we have an RCT ongoing, again, about halfway recruited, that looks at these patients versus physical therapy. There's some of the data off on the right showing good improvement in IKDC in the stem cell treated group versus the exercise group. So where is interventional orthopedics going? Well, past is prologue. So let's actually look at what's happened so far. In 2010, about 90% of all chronic steroid-resistant tendinopathy was managed surgically. In 2017, many of these same patients are actually getting PRP. And I would expect that we're going to see insurance reimbursement here, and we're going to see almost all of this become non-surgical. And what will be the big push to move to less invasive IO procedures? It's going to be insurance. We now actually, through our network, have coverage of about 200,000 lives. And these are just some of the companies on the bottom there that actually offer these through their self-insured plans. So the bottom line is, why are they doing this? They're doing this to reduce elective orthopedic surgery rates, because elective orthopedic surgery is more expensive and this stuff is cheaper. And we expect about 1 million covered lives by fourth quarter of 2008. We've just raised money to go out and continue to contract with these self-insureds. And the bottom line is that surgery plus orthobiologics is always going to be more expensive than a precise injection plus orthobiologics. So again, insurance companies are going to figure this out, and when it can be done with the same outcome or better outcome via interventional orthopedics, that's going to replace surgery. It's just a matter of a spreadsheet. So here are my best educated guesses for 2030. We're going to see dramatic reductions in elective orthopedic surgery rates, And this is going to be a blended specialty. We're going to see both orthosurgeons and non-surgeon or interventionalists who are involved in this. We're going to see orthobiologics coverage for many indications. And we're going to see many, many more procedural devices to allow more to be done than can be done today via a needle or percutaneously. So in summary, autologous orthobiologics are likely here to stay. We've seen good results clinically based on registry and RCT data. Multiple other RCTs are on the way. And interventional orthopedics is about to change everything. So thanks so much for watching and have a great day.